It's a great pleasure for me today to introduce our guest speaker to this regular series of lectures which ANZSOG has developed as part of its engagement strategy and to facilitate our collaboration on interesting matters of public import, most particularly in relation to public administration and issues of governance. And I think we all agree there is nothing more important than our health and the development of appropriate health solutions. The lecturer today doesn't need introduction. Dr Rashmi Sharma, but I will introduce her, and I'll provide some short biographical detail. Dr Sharma was born and educated in London, of migrant parents, a first generation Brit, and so I'm pleased that her children are first generation Australians. But was educated in London at Guy's Hospital Medical School at the University of London before migrating to Australia to complete her training in Queensland. Rashmi moved to Canberra in 1998 to become joint practice principal with her sister at the Isabella Plains practice, a large multidisciplinary practice in Tuggeranong. Rashmi was the past president of the ACT Division of General Practice and is the current chair of the ACT Medicare Local. She sits on a range of ACT Health Directorate and local ministerial committees, and indeed is involved in a national, and has been involved in a number of national committees, and is currently, for instance, a member of the Pharmaceutical Benefits Advisory Committee. It's a great pleasure to welcome Dr Sharma to address us today. Thank you.
Thank you. So the title for today is self-explanatory. What is the role of Medicare Locals in our new primary healthcare landscape? So, just what I'd like to try and cover today is actually why was it thought that there was a need for change, what actually happened in the health reform. I'll just skim over those, but I'm sure most of you in the audience are aware of what happened. A little bit of talk about primary healthcare in Australia, then really where did Medicare Locals come from, which is basically the divisions of general practice network, and then the challenges and opportunities that we're sort of facing at the moment now that we are a Medicare Local. So 2009, I think we all recall with Kevin Rudd and Cynthia Watson driving around the country or flying around the country and meeting lots of health clinicians and asking what the problems were. And I guess that was in response to the fact that we all know that health is consuming a larger part of our gross domestic product, and in the ACT, I think the figure's coming up to about maybe 30% of our local budget, so that's quite a frightening figure. The other issue is that consumers do report that, it's hard to get in to see someone in a timely fashion, a convenient location, and also access in terms of cost is an issue. I think we all know ourselves, having been health consumers, that if you've got a chronic medical condition and you need to see several providers simultaneously, the health system is not an easy system to navigate. We do tend to manage sickness rather than managing wellness. We're not that great at prevention. And there are also the inequities in access and outcomes. For example, you've got those who are economically disadvantaged, those with mental health issues, who do have added problems on top of the ones that everyone else has. So basically in 2010, I'm being told that there was a photo of Kevin Rudd as he was about to go into the press club and make these sweeping announcements, was that basically hospitals would be funded through their activity-based funding, and that there will be a full takeover by the Commonwealth for all general practice and primary healthcare services, basically trying to move services out of the hospital and into the community. And basically, he had a good mantra, so fund it nationally but run it locally, and I don't think any of us in this room would disagree with that sort of perspective. So what is primary healthcare? So the definition of local healthcare, and I'm not going to read it out, is actually the one that the Medicare Local has adopted from the World Health Organization. But I guess, there's a few key words in that, such as socially appropriate, you've got accessibility, you've got the fact that it's actually evidence-based, it's integrated, it's able to prioritise, it actually, enhances and empowers the community, and collaborates. And I think those are things that, we really are striving for, and that's sort of, the overarching goals of what a Medicare Local is meant to be. And I think, there are also other things like advocacy that I think are important that do need to come from the primary healthcare sector for the community. So certainly, I think those are things that Medicare Local is interested in. And I think I don't need to tell you about Barbara Starfield, who unfortunately passed away recently, basically showing that if you do have a well-developed primary healthcare system, You do have healthy populations, and that does flow into better cost efficiencies for government. So I mean, really, we do need to be investing more in this area. And then this is a quote by Nicola Watson at one of the general practice national conferences a few years ago about how the fence at the top of the cliff rather than the ambulance down at the bottom. I don't know if you can see it closely. The photo that's been provided has no fence on the cliff, and I don't know where the ambulance would be on the bottom of that cliff. It would be an amphibious ambulance. So, but I mean, that's basically saying, look, hey, let's stop the problems happening. And therefore, the thought was that we need to set up something called primary health care organisations, but the question was where would they come from, who would form them, what were they going to look like, what were they going to do. So we knew this a while ago as divisions of general practice, but we didn't actually know who was going to be doing this. So I wanted to then move on, just for those who don't know in the room about divisions of general practice, where they came from, how long they've been around for. So in the early 90s, there was an increasing sense of isolation felt by general practitioners, and I think there was also, you know, an issue about where does general practice actually fit within the overall healthcare system. These were often in those days small private practices in the suburbs. They weren't as large and multidisciplinary as they are nowadays, and so I think people did feel quite isolated. So there was a GP working group that was made up of the AMA, the college, and also the Commonwealth. And in the federal budget in 92-93, they did come up with the Divisions and Project Grants Program, and that created 122 divisions of general practice across the country, which is quite significant considering that now you've got half the number of Medicare Local. So some of these divisions were quite small, some of them only had about 60 GPs in their catchment, so, and then you had others that were much larger if they were metro organisations. I won't read out what their role was, but basically it was to, I guess, enhance the role of general practice within the community in a way that, you know, an individual GP, unless they were an absolute champion, could not be able to do. So it was providing that cohesion. So I then want to just move on to a local case study because I guess that's what I know best. So the ACT division of general practice was actually set up as one of the first, I think it was 10 lead divisions set up in Australia in 92. And it continued to 2011, so that's almost 2 decades of life when it then became a Medicare Local. So if you think, what were we doing at the time that we switched over to being Medicare Local? Well, there's a whole range of services here. Some of them are actually sort of being fund holders. So, for example, that's through the ATAPS program. And for people who don't know what that is where people who are vulnerable can actually go to their GP and then get access to free psychology services. So we were actually a fund holder and manage that program. But I mean, there's other things that are bigger things that are not related to fund holding. For example, there's a very strong emphasis on education. There was a very strong emphasis on educating general practitioners, but also their practice teams, so their nurses and their admin staff and their managers. I think e-health was a big role for divisions of general practice over the 2 decades. We saw a huge amount of computerisation within general practice. I mean, that I think has pushed general practice up to being probably one of the most computerised medical, professions within medicine there is. And then we helped with things like quality. We helped with, navigating the MBS. We also did a reasonable amount of advocacy on behalf of general practice with policy makers. And of course, in the ACT, we're heavily involved in workforce when we hit our really low workforce numbers. So that's really sort of a snapshot of, what we did for those 2 decades. It doesn't look like a lot, but it was a lot. And that was done with funding from the Commonwealth Government. So you might get a little bit of discretionary funding, but the rest of the time you would have programs that would quite clearly said, you must deliver this, and you must report to us that you have delivered this. So some of them were frustratingly inflexible, some of them were frustratingly not very well designed, and therefore didn't work very well. When, in August 2011, when we decided to become a Medicare Local, our membership was basically general practitioners and practice nurses and practice managers who were associate members. So, what happened? Well, I think everyone will remember that there were great plans for primary health care in the original plans by Kevin Rudd, but then over the years they got watered down. So we actually ended up having a much smaller role to start off with. Now, I don't necessarily think that was a bad thing because we were not-for-profit organisations suddenly being given this massive brief about you were going to manage everything. And I think some of us were quite nervous because we didn't have that experience. So I think certainly in a way you could be cynical, but in a way it might actually be better for Medicare Locals to slowly build up their capacity rather than have an overnight shift. what happened was the national body of the Divisions of General Practice, which is AGPN, I think was quite skillful in realising that there was 2 decades of information that had been, and skills that were within the divisions network, and it would be a shame to see those go for a completely new organisation. And so basically, they managed to negotiate that divisions of general practice around the country would have a closed tender process to becoming Medicare Locals in the first round. And so that is basically what happened. However, I have to say, being head of the division at the time, it was a time of intrigue, it was a time when we didn't really know what was going on, we were second guessing ourselves, we weren't quite sure when we were going to be invited to apply to become a Medicare Local, we weren't quite sure what our strategy should be, so there was a lot of, flirting with your neighbours in the surrounding divisions, there was a lot of, trying to place yourself up with your stakeholders so you get their support, really not knowing what we were going to be asked to do and what the invitation to apply would be. And if I recall, the invitation to apply came out in about February of 2011, the first Medicare Locals to set up in July. So that was not a very long lead time for us. So it was frantic when the actual invitation came out. And as I've said, look, we were very lucky. The ACT was a single division, and the ACT, fortuitously, local hospital network actually is identical to the divisions network. So for us, it was actually an advantage to go it alone. We did flirt with our neighbours for a while, we didn't get anywhere, so we decided to go alone. But for other organisations around the country, it's been difficult because some divisions have had to amalgamate. That has, and you might have heard about it in the medical media, there's been some where there's been a lot of bad feeling. They've had to go to arbitration because obviously you can't have 2 CEOs, you can't have 2 chairs, you can't have a board made up of both organisations. So it has been difficult for some. And I think the other thing is that some have opted to retain their old divisions and set up a new company. But the problem there is that the old divisions no longer have any funding from the government, so that's really an issue for these organisations now. We are hearing more and more of them are actually winding up as the weeks go by. We were fortunate enough to actually put in a reasonable application in March, and we got chosen the first 19. And I think we only had a few weeks to be told that you could start on the 1st of July, so that was interesting. However, we didn't have our EGM until the 5th of August, so in theory it was just business as normal. And then, that was really when we started in August. So we finally, as I said before, we have 62 Medicare Locals now. I think all the applications were successful in the end, all coming from divisions of general practice, and they've been rolled out in 3 tranches, with the last tranche about to start in a few weeks. So what is a Medicare Local? Well, it's not a government body, even though a lot of people say that. It's a company limited by guarantee, it's member owned. Nicola Watson described it as the polyfiller in the health system. I don't know if that's a compliment. And basically, we've been asked to coordinate primary healthcare. Well, I think the thing I want to stress, and I think this is why I spent time talking about divisions, this is not a revolution, it's an evolution. We have divisions that were already doing something, they're still doing it under the name of the Medicare Local. But what we're now doing is we have a wider brief that we need to follow. So, as I said, we became a Medicare Local in August 2011, and we've had an extraordinary general meeting, which was extraordinary because it went on for 3.5 hours. It was extremely stressful because we decided that we needed to go to our membership, which was 550 GPs in the region, and say, will you become a Medicare Local? And it was extremely stressful, but we actually managed to get it across the line because a lot of divisions had chosen to just ignore the membership, set up a new company, but we thought, well, if you don't take your members with you, you're going to fail. So we were lucky, we got it across the line. And in hindsight, that was definitely the best way to go. So we basically became ACT Division of General Practice, became the ACT Medicare Local. And I won't read out our vision and mission and value statement. They're all nice motherhood statements about integration, and I'm not saying that facetiously, but that's usually what we do see in vision and mission and value statements. But basically, we do want to integrate and coordinate. And I think the other thing, importantly, we spent quite a lot of time with our planning day on this. We do want to see if we can tackle social determinants of health, because if we don't do that, we're just going to, really not make those long-lasting changes. Those are our objectives. So we do have 5 objectives. And again, I won't go through those in detail, but we do need to know what we need to do, because one of the things about Medicare Locals is it should be sort of local planning. We should be able to come up and say, this is a problem with Bruce. Particularly, let's come up, I don't know any calls in Bruce, but you know what I mean. And so we'll come up with a solution tailored for this region. We also want to improve coordination. We also want to make sure that the providers in the primary healthcare sector are well supported. and we want to, implement successful primary healthcare initiatives and programs, and we need to be accountable, we need to have a strong governance system, we need to make sure that our directors know what they're doing. That was brilliant. That was meant to be our strategic plan on one page, but sorry about that. That was your interlude. Okay. So, just quickly to let you know, okay, so this is what we have in the current Medicare Local. So we have a skills-based board of 10 directors, and then it has some board committees. You've got your normal ones like finance, audit, governance. We've also got a clinical governance committee which will advise the board, which is about to have its first meeting, and there's that's going to be upcoming. We're going to have a GP advisory committee, and one of the reasons we're having a GP advisory committee is that the funds that were carried over from the Division of General Practice into the ACT Medicare Local have a caveat around them about general practice, and so the general practitioners are going to be able to advise us on that. Community Advisory Committee is the Committee of Consumers, and then we have a Population Health Committee, because that is really an area that we need to work hard on to try and do some local identification. At the bottom we have the Primary Healthcare Advisory Committee that also advises the board. That is a very large committee with people across the sectors. You'll have your consumers, you'll have your allied health, you have your GPs, you'll have your stakeholders and your service providers. It's a committee of about 25. That has already met, and they endorsed our strategic plan a few months ago. Just membership, and I'll just talk about this very briefly, because all Medicare Locals, and this is one thing, they are not all the same. So the Medicare Local in the ACT is very different to the Medicare Local surrounding it in terms of membership. We've all been allowed to choose our own membership models. We personally thought that we wanted to continue engagement with our members, and therefore we have allowed individual membership, and I think we're sitting at about 1,000 members as of now. And that is comprised of a class of general practitioners members, we've got a class of allied health members, we have stakeholder members, such as, for example, peak bodies, so ANU, GP training providers, I think the UC is a member as well, if I'm correct. We then have the consumer organisations, and then we have service providers, and that means anyone who provides a health service. So, for example, my practice is also a member, or the local physio practice may be a member. So we've sort of done that to try and be as inclusive as possible. And you always have to have a really busy slide in your PowerPoint, and no one can read it from the back. But basically, we're really trying to do a bottom-up approach here, because that is the whole point. And I think if we lose that, it's going to be a shame. So really, you've got to have your people, your processes, and your systems working out and developing your core capabilities that basically then meets and melds with your stakeholder requirements, and the outcome for us is better health outcomes for the ACT community. That is our goal. But we know that along the way we've got to work from the grassroots level, and we've got to be mindful of our stakeholders and the people that are actually going to help us reach that goal. So, what does it do? I think you might have noticed that some of these things were what the division did. So a lot of these things have carried over. Green is non-discretionary. These are programs that we get funding for from the Commonwealth or from the ACT Health Directorate that are basically contracts, and we have deliverables on them. There's a little bit of flexibility in some of them, but not a lot. And then the blue ones is basically discretionary. So we have an element of funding that we can decide what we want to do. So we've decided that we're going to actually keep some money in nursing and general practice because the program funding is going. Population health, because we really do know what's going on in our area. Practice support, and practice support is interesting because we need to now take this out to a new area of practice, which is allied health practice, which is very different to general practice. Allied health is extremely varied, and this is obviously a challenge that we're going to have to face. And education. So I've put multidisciplinary CPD. We're now holding events where everyone can come along. And the beauty of that as well is that not only is it good in terms of education, but you actually get to meet your local pharmacist, or you get to meet your local physio who you've spoken to on the phone to for years, or what they're sort of. And that's a great way of building up integration. How is the Medicare Local different to the division? Well, there's your equation. New activities, revise the old programs, maybe get rid of them if we don't like them and they become a Medicare Local. That's not going to happen overnight. Some of these programs that I say are funded by the government still have 3 years left to go on their contract. So this program is still going to be running. So new activities, you've got, and I've talked about this, but new things that we are doing, for example, we are getting a secure messaging service for allied health providers to communicate with general practice. We're trying to get a couple of e-prescribing systems for pharmacy. We're helping with the health services directory in the ACT. We've now got communications going out to all members. A new program that we have had to take on is access to after hours. health care services, and that's not just general practice. We're working with pharmacy to try and, this is still embryonic, but to upgrade your pharmacy education in terms of after-hours presentations, and actually to make it attractive for pharmacy to open after hours, because there's no point seeing a doctor if you can't get the medication. And population health promotion, and just talking about the Canberra Health Alliance, that's an organisation that's going to be launched next week, which is basically a group of non-government organisations and the Medicare Local actually getting together to brainstorm and see what we can do on the ground and make a difference. So, challenges, because everyone says that we're going to die in about a year, I think. So I guess there are a few challenges. So the first thing is expectations, because we're going to be responsible for everything. I think we're probably hearing that. I think the Preventative Health Agency has told us that we're going to be responsible for preventative health. And we're going, oh, are we? We didn't know that. I mean, I think we knew that, but I mean, everyone is just saying the word Medicare Local almost, flippantly now, as well, they'll do that. So I think it is hard. We do not have a huge amount of resourcing. Our resourcing is not much more than a division of general practice, and we've now got to cover a much, much wider base. There is also a temptation to do the easy things. There's a temptation to sort of do the low-hanging fruit, but actually, which I think you do need to do, but I think you've also got to think about bigger picture stuff as well. And I think the other thing is locally tailored solutions. There's no point if we come up with a really good idea that, for example, AC Health Director says no one is interested. We've got to get buy-in from everyone because we can't fund a lot of these things. So other players have to fund. The other challenge is new members versus old members. We have a general practice membership. We now have a much wider, diverse membership. But the challenge is to keep the general practitioners engaged because I'm a GP and I'm biased, but you don't have general practitioners. Primary healthcare has a huge chunk missing. But we've got to keep the other people engaged as well. And I'd be glad to hear that almost all our GPs are signed with Medicare Local. So we've got about 450 GP members. The others who didn't sign were sort of outside the catchment areas. So we've been very fortunate to actually keep that going, and the new membership is growing every day. I think the other challenge is that, as you know, primary healthcare is private and public, so it's not just all private practices. You've got community health centres, which are funded by the government. So at the same time, we're trying to work both for these two sets of people. Health system is resistant to change. Well, it is resistant to change. We all know that. We're all crusty. We all like our turf wars, and all the rest of it. And I think it is going to take a while, but I think primary health physicians do much better than guys in the hospitals. So I think we've got that added advantage. But we've also got to get the guys in the hospital to respect our role in healthcare. Social determinants, it's great to say we want to influence them, but that's easier said than done, and that is really long term, and that is also making sure that we're around the table. Measuring performance as well. Look, we've just been given a COAG performance and accountability framework, which lists all our indicators, some of which we will not be able to do without the local hospital network's help, some of which you don't even know what we're measuring them, because is it going to make any difference in health outcomes? They're starting pretty low level at the moment because obviously we're not putting too many expectations on us. We don't actually know the time frames for those. I think the other thing is generational change, being patient, because things we might do now may not pay the dividends for about 10 years. Political environment, because we may not be here in a year if the coalition gets soon, that's what's been said. The reality is, though, the division of general practice have been around through both types of government, coalition and Labor. And so I think the reality is they'll know that something will need to be here. They may change the name, that's what they're saying the name change. I don't know, I can't say any more than that. We've also lost our state-based organisations, and for those who aren't aware of that, look, the ACT had a slightly sort of complicated role. We were a division, but we're also a state-based organisation, which meant we've got a little bit of funding to go and talk to our local politicians and our local health directorate. That's gone. Now for the ACT, look, it is a pain, we've lost some funding, but it's probably not that too difficult to get around because we're a small town and we can still pop into the Legislative Assembly or whatever. But if you're in New South Wales and you're a Medicare Local in North West New South Wales and you've lost your organisation that actually goes and talks to the New South Wales state government, that's actually, I think, going to be a bit of a risk because there's going to be a lot of funding going into travelling to Sydney, or you're actually not going to be relevant at the state level. And I think, we do need state governments to be involved in this. The other issue we know in the last budget was that the League Commission was being defunded, which is a problem because, that was actually a way of actually saying, let's have a bottom-up approach, let's do our own solutions. Opportunities, though, are, let's get the focus out of the hospital and let's get it back into primary healthcare. And, improve the patient journey. And I always say this, and I know Darlene hates the word patient journey, so but clinician journey, because I've got to tell you, and any clinicians in this room, it is just as bad for us trying to get people into the system and navigate it. I spent an hour the other week just trying to get a psych appointment, and my problem was, oh no, you're practicing Tuggeranong, but they live in Canberra, so they can't go to the Tuggeranong service, they've got to go to the Woden service, but Woden wouldn't take me because I was in Tuggeranong, and I was just like, so you know, those, and that's just a very minimal example, but I mean, I think that will help. Encouraging the sectors to work together, I think, is really important. Relationships with local hospital networks, we're lucky in the ACT, we have the same boundaries, and I do actually sit on the local hospital network council as the Medicare Local rep. We've also got opportunities to actually look at things in our own area now, so to do good population health, and then plan from that, and then be able to actually come up with really good health promotion programs and enhance e-health. Flexible funding possibly is a possibility. I've said that two possibles because it's very embryonic. We don't know. They're going to pull some money together. We're not quite sure if it's going to give us flexibility. We're not sure yet. But if that happens, that would be great. Because we've got individual membership, I think that bottom-up approach is vital stuff is going to work. I think we've got a real opportunity to help allied health providers because I think they have been quite isolated for many years. They don't have their colleges in the ACT, they don't necessarily have professional bodies in the ACT to help them. And then we've got these partnerships and alliances. And I guess the thing at the bottom is we want to be the provider of last resort. And what that means is if, for example, the Heart Foundation is doing something really well, we wouldn't want to go and duplicate it. We would actually want to say, look, we found that this is a gap. Could you please go and move in this area rather than duplicate? Because I think that's one of the problems that has happened. So just to let you know as well, though, so the other components of health reform is AMLA is the new name for our local body, okay? And I think it's not our local, sorry, our national. I think it's really important you have a national body because you do need people going up to Parliament House and just reminding them that there is a world outside of hospital. Local hospital networks, we talked about the ACT is slightly different. It has a network. Other areas have a slightly sort of organisation that has a little bit more teeth, whereas in the ACT we're more advisory. We are hopefully going to have a clinical senate in the ACT, even though the funding has gone, because I think that would be really useful if we've got a mix of hospital and primary healthcare providers all in the same room, talking at the same time. I think that's a huge step forward. We've got the Preventative Health Agency, which I think last week did say that Medicare Locals would be responsible for preventative health, so that's another job on our list. And I think the changes in the hospital pricing, which is going to come up, will make a difference because there might be, a will to actually move some of these people out of the hospital back into the community and more of a focus on prevention and health promotion so they don't end up there in the first place. So I think there are opportunities there. So this is my final slide, and it took me a while to write this, but I don't want it to sound too cheesy. But look, I think they are on their way. I don't think they're just starting, I think they are on their way. Some are more advanced than others though, because don't forget some of them are only starting up in a few weeks' time. And we've been very lucky in the actual organisational structure that we chose. We do have a much wider membership base, but I think that is an advantage. And we also have a really enthusiastic and experienced workforce, and I'd like to say that there's a few very enthusiastic, experienced workforce in the room here from Medicare Local, and they do an absolutely great job. But I do think they do need to be respected because they should be significant players in the health policy field now. And even though we don't have much funding, because unfortunately the dollars does often give you clout, I think people really do need to listen to us because we're really that conduit down to what happens in the field. I think also listen to them because we don't always come up with silly ideas and allow us to influence. But I mean, bigger term, they do need to be resourced if they're actually going to be able to deliver properly. And I think also, and I put the last one is, allow them some control over their own destiny, because if in 5 years' time they are still rolling out programs that really don't make a difference in the community, are cumbersome to roll out, then people are just going to get disengaged. I mean, this was an opportunity to have a bottom-up approach to actually healthcare planning and delivery, and I think we really shouldn't lose goal of that, because ultimately then, and it was also an opportunity for consumers to get involved in primary healthcare planning, and I think that's a first that we've got. So let's not lose sight of that. And that's me. And I think that was why I said one of the challenges is you're looking at a private sector model, which is the pharmacy, general practice, the private physio, and then you've got your maternal and child health nurses who are down the road from your practice. We actually have a lot of maternal and child health nurses and community nurses as our members. We've got nurses from the walking clinic as our members. So they are actually then get all the benefits that a member would have. So for example in education, and things like that. But I guess on a bigger policy level, that is, I think, or planning level is, of course, that's where the challenge is, because we don't want to be duplicating what's done really well in these centres and are done very well by these health professionals, which is where my slide that says, look, we're last resort. We want to enhance what is done, that's already being done, and it's being done in general practice for years. They've got more and more nurses now working in general practice in the ACT, and that's a great thing. But I can't substitute for the community midwifery program, for example. Neither do I want to, neither do we want to as a Medicare Local. We just really want to enhance the services that are there, but then connect them together a bit better, because I think the connections are still quite poor. Look, I think if we do get this person in control of electronic health record up, for example, hopefully by the end of the year we'll actually see it coming through, then that is an opportunity where, for example, and I can say that as a GP, a lot of my patients do use great services in the community like Therapy ACT, but there was still no communication messaging back to anyone. And in fact, I don't write letters to them, so I'm just guilty. And I think so if we can get the communication better, I think that solves a large problem there. In terms of actually getting the sexes to work together together better. And I think the other thing that a lot of people have said is that we actually don't know what's out there. So I don't, for example, know that my maternal and child health clinic can actually do X. If I'd known, I would have sent people to them ages ago. So I think it's also getting the health services directories really up to scratch so that we're all very aware, because the ACT is a really difficult place to navigate, because there's a lot of people doing the same thing and not knowing that someone's doing it next door to them or doing it better than them. At the moment, we're still working on our population health, which I guess is part of that. We have been invited onto a few whole of government committees that are there. There's one that's dealing with obesity, and it's a whole of government committee, so that would certainly be a step in the right direction to actually try and influence those. We have academics on our board. I've got Gabrielle sitting there looking at me, who certainly will guide us in that. But we do have good relationships with our universities. We certainly do, and one of the things in our strategic objectives was actually making sure that what we do is evidence-based and can show an outcome. But social determinants of healthinism, they take a long time, and so we are certainly planning to do that, but we've also got to be mindful that we have to do some short-term things as well. As a GP, I don't give people my data because it's mine. Why should I? What am I going to get in return? So I think, Australian Institute of Health and Welfare may be crunching numbers, but it's not actually crunching numbers from actually what's happening. And you do have things like the Beach Survey, and sorry Marianne, correct me if I'm wrong here, but you're not necessarily getting a lot of data out of general practice. So the opportunity that we're hoping as a Medicare Local is actually get data out of what is happening in the ACT right now, or in the past, and then actually build a picture of little local areas, and actually be able to then plan for the future. We want to go bigger than that. We are trying to get PBS data, but of course we've got to deal with the authorities to be able to get that. And then we also want to try and get some pharmacy data as well. Our big problem though at getting data further than that is that a lot of the organisations, such as other allied health services, do not have computers. They do not keep data. So we've also got to look and investigate what data sets are there out there that we could utilise. And I think that's probably our difference, is that we're actually going to get right in, see what's happening locally. And then, but we have got the Australian Institute of Health and Welfare on our population health committee, so they are working with us. I don't think we have actually decided on that outcome, and I sounded very evasive. I mean, because it's very difficult. Like you can measure 4-hour emergency times easily, but as I think as someone said very eloquently on the weekend, it's difficult in primary healthcare because someone's mother might have died and they might have just been evicted, and therefore, you've got all these other things that affect their health that only really happen in the primary healthcare space, and therefore we've got to be careful what we try to measure and make it meaningful. So, for example, with diabetes, diabetes would be an easy one. We could just pick the HbA1c indicator and say, okay, if we implement this, if we want to go wider, then that's going to be hard. So, I think at the moment we're still working around what should we look at. But in the meantime, we're getting the infrastructure in place to get the data. it's interesting because on the one hand we're being told that we won't be around in another year, and on the other hand we're getting messages that actually no, we realise now we really do need to sort of enhance and entrench the role of Medicare Local. So I think you will find that funds will hopefully flow with that promise, okay, possibly, you know, from the Commonwealth. But the other thing also I think, and you know, this is very rudimentary conversations that I've had, for example, with the Health Directorate, is that they realise that they cannot sustain this growth. You know, it's not going to be sustainable in terms of their capacity. And so they're actually looking for ways to move things out into the community sector that shouldn't be in the hospital, but of course with that, there has to be some dollars. Okay, so we're not going to be silly enough to say, oh yeah, we'll do it, but we'll do it for free. Of course we can't, because our members will all leave, and you know, it won't be a good look. So I think, you know, with that, we obviously have to say, well, okay, fine, we agree this should be in the primary healthcare space, but you know, we've got the complexity, the majority of us are private providers. So, you know, you can't, we still have to run businesses, and even if you do move it into their public sector areas, they still only have a limited capacity. So certainly we'd be hoping that as that realisation comes that the acute sector and the hospital sector can't cope, they'll actually move things out, but they will have to come with adequate resourcing. I think it's a difficult one because even if you look at, for example, our performance indicators, they're pretty much ones that you can't translate into prevention at the moment, or you know, healthy outcomes, and I think that's a problem. But I think that's probably being quite a purposeful action, so that we don't have a brief that we're going to fail on straight away. I think they realise this is going to be a change over several years. You know, in a decade, this talk will be very different if we're still around. So I think really let's actually get processes in place. For example, population health. If we have really good population health analysis in the ACT, then it'll be much easier for us to then say, well, why is this happening in this particular catchment area? Then develop a program and then measure whether or not we've got an outcome. But those things don't happen in months or years. They happen in sort of, you know, a long time. And that's why I think, you know, although we all want to do population health tomorrow, it is a long process, because even if you do recruit, you know, in the first instance your general practice because they've got computers, a lot of the time their data's very poor. Because if you don't input the diagnosis correctly or your drug database is wrong, it doesn't give you any information that is meaningless. So we've got to go right down to the bottom level saying clean your data up. You don't only put, you know, and there are great audit tools out there now that can tell you the frightening statistics about how many blood pressures have not been measured in your patients, you know, and things like that. So, I mean, certainly those tools are there, but to get it, you don't want to just get rubbish data, because if you've got rubbish data, you're not going to get the answers that you want. It is actually building those relationships as well. And you know, last night we had an allied health, I think I mentioned this, but you know, we actually got the allied health providers together who own practices and said, what do you need? Because we know what general practice needs, because they've only got 5 types of software, they all follow the same accreditation process, but now we've got this whole vast array of different businesses and different models that need different support. And that's a challenge for us, but we're starting slowly, and you know, we have about 500 allied health members, so hopefully they're going to think that there's going to be some value being our members. Well, I sat through a presentation on the personally controlled electronic health record last week, which, you know, I think is a great idea. Of course, it's going to be launched before it's actually going to be ready, but that's what always happens. But, you know, it was really interesting because someone said in the room, because this was actually a meeting of GP business owners, practice principals, well, what benefit will it have for general practice? And the reality is, and the answer was, well, actually, the thing is, you're actually probably going to be putting most of the information on it. And the risk is that the other people aren't going to do that. So the risk that really what we have to keep lobbying and trying to change behaviour is that the acute sector actually realises that patients do leave the hospital. And that when they leave the hospital, they do often go and see another health provider, and that health provider really needs to know what's going on. And I have to say, working with the Health Directorate closely, I think they agree. And I take my hat off to them. They've been working really, really hard in that area. But but I have to say the culprits are the clinicians and usually the doctors, okay, who just don't think that a life exists outside the hospital, and they don't think that anything else happens, and so we often struggle to get those flows of information. So I think when the personally controlled electronic health record comes out, we have to basically just keep bashing everyone up until they actually come to play, because if the ED department do not put that episode on that record, it's not going to help them when they come back to see me. I must admit I'm really IT unsavvy, but my understanding is yes, everyone does. As long as the actual consumer gives their consent, then anyone can load information up onto it. So because it's held in one of those things called clouds. So I thought they had a thumb drive. Sorry, that's that bad. I need to be hard told, but no. It was nothing about thumb drives, so there you go, sorry. Look, I mean, I think if we can get electronic messaging between allied health and general practice up and running, then I think that's going to be a help for consumers on the ground. I think, because part of your journey is actually just that navigation. Part of your problem is also just navigating the system. So I think if your health workforce is better informed, then of course that's going to translate into making your job easier as well. So I think, certainly yes, and I know that at the end of the day, our final objective is to improve the health of the community. It's not to make sure that you've got a brilliantly run general practice. We actually want to get some health outcomes. And I would be saying that, that is why we do have one of our board committees as the Community Advisory Committee that is made up of people who are from health consumer organisations to guide us in our actual direction. And I think as part of that Primary Healthcare Council, there was a vast array of consumers who actually made suggestions, and we did actually change our strategic plan. So getting that input was great. But I think, of course, you want to see the deliverables on the ground, and that's why we are trying to go for some low-hanging fruit, like, for example, making communication better. But at the same time, we do want to do those big generational changes, which, will empower consumers to look after themselves. But that might take a decade, and we'll need consumer input, because without that, it's not going to work. Look, we always had very close relationships with our neighbours in terms of the division of general practice, and I think they've got the same footprint, albeit slightly altered. And so we still do work with them very closely. And it was quite interesting for us as an ACT Medicare Local when our boundaries got redefined, because probably about 1/4 of our membership was actually in New South Wales. And the question was, well, we're not going to get any funding for you. But we didn't want to say see you later, because I live in New South Wales. And so, it is a myth to say that I have patients from Queanbeyan who come and see me in Tuggeranong, and some of my patients in Tuggeranong go to GPs in Jerrabomba. Some people live in... So, it is a myth, though they are artificial boundaries. So one of the things that we did was we grandfathered all existing members in. So they still have access, and they're still full members of the ACT Medicare Local in terms of allowing those people to come across. And we still do a lot of cross-border education, so that's sort of, the grassroots, and we will go out and support, and we're certainly talking to our neighbours about, well, look, how about we deliver this for you, because there's no point you driving up from Maria to go to Queanbeyan to deliver something, well, we can do it for you from the ACT. So that collaboration and collegiality works, Medicare Local to Medicare Local. Local hospital networks, I think, is different. We haven't actually met with them yet, and I think that's probably because the ACT Local Hospital Network hasn't met with them yet either, so I don't think we should be meeting them before then. But certainly I think with the future, if anyone's brave enough, would actually be to maybe extend boundaries or, have a mutually agreeable relationship that doesn't just stop with funding. Because I can tell you that when our boundaries came up and there was a proposal, well, New South Wales GPs and Queanbeyan, that, they can't be our members now, there was a huge uproar. They were really upset. They wanted to, because, they live, essentially, closer to the ACT than they do to Maria, so it was nonsense. So we've included them, and we'll just wear that. I think certainly we'll have a greater awareness of what is going on. I think the whole point of things like health services directories is that hopefully you'll get one done in your neighbouring region as well. I think there has always been a problem, though, that if you have a certain address, you can't access those services across the border. Am I correct, Darlene? It's very boundary-based in terms of primary health care and community health services. I think it is. So I think, look, you know, I can't really answer the question. I mean, I think as we get more information about what's out there, but I can't then say that there's a really good service in Queanbeyan. I don't think my ST patient at the moment will be able to access it. But I think that, I mean, I sit on the board of our GP training provider that's based in Wagga and does the whole South East New South Wales footprint. So, you know, there are state and territory boundaries, but it works really well. And so education, I think, is always the unifier. And I think it's a good stepping stone to move further. But I think the problem is that while you've still got bills that you're waiting to be paid from New South Wales to the ACT in terms of patient care, you can't really move on until they've resolved